Yeah, well, I wanted to thank you, Whitney. I know this is your first go around with CEwire, and I guess your talk is coming up in a half hour, right?
Correct.
Great. So hopefully it'll go well for you. It's funny, we have spoken over the past day and a half with, I think, just about anyone who is anyone with ocular surface disease. I think that's safe to
Oh,
say.
well, good. Good,
So
good, good.
so this is great. So we've had Art, we've had Laura
Kathy Mastrota.
Perryman, we had Kathy just a few minutes
Yeah,
ago. So we've had the cavalcade. So this is
I got
great.
on. I
Yes.
got on to Laura's yesterday briefly and said hi to her, and I said hi to Kathy, who was on Laura's. So,
Oh, awesome.
yeah,
Yeah.
yeah.
Yes.
So it's a small group of friends for sure, and obviously where all the cool kids are, because nobody likes retina.
Oh
That's
my
a
God.
dark, lonely place.
Yeah. Well, I saw that you're going to be doing something about the DEWSII study. So we've been hearing a lot about this. So,
Yeah.
so what is your talk all about?
It's like you said, it's kind of. I mean, when I say 30,000-foot overview of DEWSII, it really is. I mean, it's such a comprehensive report that
Sure.
no 1 2 hour CE can do it justice. So,
Mm.
what I tried to do is take it from what would, in my mind, be the most clinically relevant pieces of it, because that's what most practitioners want to know is how can I implement something new in my office, and that's really what I tried to do is get some of the diagnostic recommendations, treatment recommendations, and then how would you use that in clinical practice.
Right.
Right. And so this is basically for the general OD who might not be totally up to speed yet on the study. So this is giving them the big overview of it.
Well, it's
Right.
it's
And I
hard to
mean,
be up to speed. I mean, that's a massive document
Yeah.
that you guys
It
put
is.
together.
It is. I mean, it's like sitting down with War and Peace. I mean, it's just hard to sink your teeth into to know really where to get started. And people like me, and you mentioned Art and Kathy and Dr. Perryman. We all just live, eat, sleep, breathe this, and just throw ourselves into it and enjoy it because we speak on it, and it's just our area of interest. But if you're in primary care optometry or ophthalmology, and you're doing wearing a lot of different hats, it's hard to take the time to find what you need and drill down.
Sure.
Sure.
What's interesting, I spent a couple of days on the road with Crystal Breimer last month where we give talks about dry eye. And she
Yep.
talked about sort of her technique and her algorithm that she uses to try to diagnose and treat. And then, of course, we had Art on yesterday who's got his own algorithm and his own take on things. And to me,
Right.
what's interesting is that it's, in the olden days, I guess you just threw everything at the wall and whatever stuck. But now it seems like this is getting much more refined and scientific in terms of what people are doing and how they're doing it. Do you have
Right.
your own algorithm that you like to implement? Is it any
I
different?
do. I do. And to sort of come off of what you just said, I mean, not only did they throw it at the wall and see what stuck, a lot of it was, here's your artificial tears, see you in a year.
Yep.
And because of the lack of vision-threatening nature of the condition and more or less a nuisance condition for doctors and patients alike, it was easy to just sort of table and set off to the side and wait to see if something, worse manifested. And I think diagnostically we have more things to really hold on to and sort of prove our point, and more treatments available now than ever before. So there's a lot more opportunity there. To your question about do I have my own algorithm, on my website, dryecoach.com, I actually have a treat section. And the treat section has sort of a tiered algorithm, if you will. And the tiers are not really even so much about level of severity of the disease, although there is an element of that. It's also about your practice's commitment to treating the condition, what equipment you have available, and things like that. And I worked on that with Dr. Alan Cabot, and Alan and I are good friends, and he was a significant contributor to that too.
Cool. And actually, I'm pulling up your site right now. So it's dryecoach.com. So we absolutely will give it a plug here, and I'm looking at it right now. Very cool.
Very good. Yeah, we're a peer-to-peer, and when I say a peer, I think we're the only peer-to-peer education site for ocular surface disease. And you could, as an eye care provider, whether it be optometry, ophthalmology, or staff in terms of technicians, you can jump on there and get quick pieces of information for treating dry eye disease. And it's from the names that you trust in both optometry and ophthalmology, key opinion leaders who really know their stuff.
Yep.
Whitney, let me take a step back. We really didn't properly introduce you. For those of you that don't know where you come from, you're an
Everyone knows.
associate
Yep.
professor at Southern College of Optometry. And we had a
Right.
whole long discussion about SCO the other day on ODwire. It is the only optometry school that has 100% pass rates on the
Yeah.
national boards.
Yes.
Oh, wow.
The fix is in. How did you guys do that? Who did you
How do you
pay off?
manage 100% of anything?
Yeah.
Yeah. Well, first and foremost, let me say I do wear two very independent hats. One where I'm the founder of DryEyeCoach.com, and I have my own consulting company. My other hat, as you mentioned, is being an associate professor at Southern College of Optometry. I'm also an SCO grad. I finished my residency there. We won't say when, but many years ago, and we're really proud of SCO. I think it's an incredible institution. The faculty there are, wonderful, not only clinicians, but educators. And I think our board scores really reflect that.
Yeah, it's interesting. And, I was surprised, since you're in academia, I'm sure, I don't know if you were surprised seeing the results. I don't know if you looked, but the wide disparities in the schools, that really surprised me.
Well, with the
Right.
newer
You know-
schools, that's no surprise, right? The newest three.
Yeah, it's,
Right. There is a certain, learning curve to board passage. I'm sure, SCO really, hones in on that. We try to pick the most qualified students, and hopefully they pick us back. And we've been really fortunate to have really strong classes, and they're just students that, frankly, and this sounds a little silly maybe, but they're just really hungry to know optometry, and that really makes the board passage even better, is when you have students that just want to know things.
Yep. Of course, in Michigan, what they did actually to keep the board scores high at the medical school anyway is they try to get rid of people before the board exam who they knew couldn't pass. So they failed out like 15% of our first year class.
Our attrition rate is exceptionally low. So we retain our students. Very high rate. I couldn't quote the rate, but a very high rate through the completion of the program.
So you must select them really well. That's good.
Exactly what I was going to say. That goes down to your admissions process. And there's been a lot of conversation lately about the number of available slots and the number of applicants and what does that mean. And we could sit here and talk about that all day, but I think that says something very, very laudable about your admissions process.
Right.
It really does. And I'll tell you what, when you come to SCO, and if you've ever been there, you'll know this to be the case, it is from top down or bottom up or whichever direction you want to go that you get an exceptional experience. When you come in through the front door and you meet Joyce, the security guard, and our other security team members, and they greet you on the day of your interview, you already feel like you're one of the family. And our student ambassadors that tour our students are exceptional. Like you said, our admissions group is wonderful and has been there for many, many years and does an incredible job. So it's just a warm place to be, and that sort of carries through your entire SCO experience. It's very familial being there.
I can attest to that because I had the pleasure of going to SCO a couple of summers ago. Louis Reich, who is actually now dean, he wasn't at the time, but he asked me to come down. And Whitney, what you say is exactly correct. It is a really great, warm place to be. And I wasn't a student. I mean, I was just simply a visitor, and everybody was very kind. And I wonder if some of that is good old Southern hospitality, too, being in Memphis. But it really is a cool facility. And I guess I'm a total geek because I really get my kicks out of going to see different optometry schools. And I like to see the differences from school to school and region to region. And
Sure.
I had a great time going to see SCO.
SCO is in Memphis.
We're always
correct?
proud to. Yes, it is in Memphis, Tennessee,
right.
and we're
It's a nice city.
we're always proud to tour people around and offer them barbecue. That's always the follow up.
Oh, wait a minute. I
Tour
didn't
of
get
the
any
school.
barbecue, so we might need to
Well,
have
then
that
you have to come
conversation.
back.
I have to.
If
I
you
need
go to Memphis, I once was there, believe it or not, I did a talk for the Mississippi Optometric Association,
In Memphis?
but they decided to have the meeting in Memphis.
Wow.
I don't know what
Oh,
that
I
says
love
about Mississippi.
Yeah.
Well, in those days, maybe, I don't know, but they had it at
I've
the
done that.
Peabody Hotel, a very special hotel to be at, in those days at least.
Is that still there, Whitney? Because you can't trust his
It is.
memory.
Yeah, that's
Like,
right.
No, it is. It is. It's an exceptional hotel, a fine old Southern hotel.
Yeah, they have the
when I did
ducks.
the Mississippi meeting, we did it at the Hilton in Jackson, so you lucked out.
Yep.
Oh my gosh. Well, great. So yeah, so I'm looking over your site right here, Dry Eye Coach, and this actually does look really interesting. I'd never really gotten a chance to peruse it before, but you have a ton of content
Yeah.
on here, a ton of printable content as well. So there's all
Yeah,
kinds of stuff.
we try to keep it really fresh, adding a lot of video content. The videos are very short because I know most people's attention spans like mine. We live in a real quick-moving digital society, so we try to kind of keep it bite-sized and useful. I'll tell you what has been our greatest success probably to date are our podcasts.
Hmm.
We have between 50 and 65 listeners every week to our different podcasts that we put out, and it's really just conversations like the ones you and I are having right now, where it's just one-on-one. How do you do what you do? Why do you do what you do? From people like Paul Karpecki and Scott Schachter and Laura Perryman and all those experts in eye care.
Very cool.
Let's take it back to TFOS DEWSII, Whitney. If you had to pull out two or three or 4 points from DEWSII to tell your fellow colleagues that this is what's most important about this report, this is really where you need to bring it home, what would you say to them?
That's a really hard question to answer, but I'm going to do my best to field it. It depends in part on your area of interest, because there's different categories. The first thing I would encourage someone to do is just look at the categories and see what you really either need to get educated on or would be more, fulfilling to your practice. One of the interesting things for me was how they changed the definition of dry eye disease. In the 2007 definition, they added the multifactorial nature of it, and that really holds true. And that is usually the diagnostic downfall of dry eye is the fact that we want to make it one thing, and it very rarely is just one thing. It's probably the patient's, age and medications. It's perhaps their lid mechanism. Are they closing their eyes all the way? Do they have blepharitis? On and on and on. But that was 2007. As we go into 2017, when DEWSII was published, the interesting piece that they added was the neurosensory phenomenon, and the fact that we have this diagnostic mismatch, which always puzzles doctors and frankly drives patients crazy too. Symptomatology will be high, signs will be low, or vice versa. And that discordance between signs and symptoms, is frustrating to both doctor and patient. And really the new report addresses that and says there could be something there that's neurosensory that perhaps requires pain management versus anything in the optometry or ophthalmology world. Of course, we have to caution ourselves about that as well, because, you can't just say, okay, well, it's neurosensory, go to see a pain doctor. It can also be preclinical where you're not getting those signs yet, but someone's going down that path. So caution has to be exercised when you're considering that. But this is really the first time that we've seen that. And for me, that is one of the most, I won't necessarily say the most, but it's one of the most interesting things about the report.
I think that's a really important component, and that's some great take-home information, because TFOS DEWSII reports are great, but it's really deep, it's really dense, and it's for the practitioner who doesn't have a lot of time to dive into it and sit there and just wants to get a few key points. That's why I'm glad that there are people like you to drill down and give people some solid information that they can take back to their practices when they go back to see patients tomorrow morning.
What's also impressive is I noticed that more ophthalmologists are becoming interested in dry eye now. It isn't just a passing fancy.
Right. And two reasons, or two things I would point out. At the ACOS meeting just this year, they had more talks about dry eye than any other disease process. So, we're seeing our ophthalmology brothers and sisters embrace dry eye disease, and, it's to everyone's benefit. Certainly the surgical impact with dry eye disease is significant. From a preoperative perspective, we need to address it, and then from a postoperative perspective, for years, really what we did was manage the fallout from failing to manage ocular surface disease prior to surgery. And, it's exciting to see like you said, ophthalmology really embracing how this can impact their results. And a lot of research has really, validated that.
Right.
Perhaps too, ophthalmology is realizing that dry eye can affect other things in which they're interested in. So if you're going to jump into any surgery, well, you need to have a good solid ocular surface that can affect so many other things too. So I think the more people talking about it, the more people thinking about it and trying to address this with patients is a good thing.
Right. One of my favorite studies in 2015 was Alice Petropoulos and Cynthia Matosian's study on biometry readings preoperative to cataract surgery. And they took a patient population and did some initial testing and found that the hyperosmolar group had very different readings if they did it 1 week and then 3 weeks later did their biometry or their IOL calculation. So much so that it could be a diopter difference in between the initial readings that they did and then 3 weeks later. So
that's a big difference.
It's a huge difference, and that is a huge impact to somebody's quality of life going on for years when they come out with a diopter different in one eye. And I worked in a cataract and LASIK practice for a decade, and there would always be this one patient that was a refractive surprise. And you thought, why did it turn out like this? And you roll back through all the preoperative measurements and think, we did everything right, crossed all the T's, dotted all the I's. And as I look back on it, I think we probably didn't pay enough attention to the ocular surface.
Yep.
You're probably right.
Indeed. And so I just have one more question for you before you got to get out here. I know to get to your class, but if you look into your crystal ball,
Sure.
and I know that there's a bunch of new stuff in ocular surface disease, like the trigeminal nerve stimulation and so forth. What do you see going forward,
Correct.
maybe over the next year or two, in terms of treatments?
That's a tough one to answer. There's a lot of things that are in clinical trials right now that haven't made it to market. I think we're going to see more in terms of thermal treatments that'll be emerging. As you said, things like neurostimulation. I've really been impressed, I must say, with the use of TrueTear. I've been lucky enough to be one of the initial doctors that got to have that in our practice, and it's been really surprisingly impressive. And in fact, I probably should have given it more credit out of the gate than I did. But I think there are a lot of new things. There's going to be some new diagnostic things that are emerging with inflammatory markers. And, as I look across the country and talk to different colleagues, a lot of them are just like ophthalmology, just starting to really sink their teeth into this. And as exciting as the diagnostics are, as exciting as the new treatments are, what frankly is most exciting to me is seeing it catch fire in the optometric community, that people are getting excited about treating it and what it can not only do for your patients, which is always foremost in our minds, but what it also can do for your practice.
Mm-hmm.
Right, of course.
Indeed.
Absolutely.
All right. Well, Whitney, thanks so much for being here with us today, and good luck on your class.
Yes. Enjoy it.
Thanks. Yeah, I guess I got to get to class.
It's always great to talk to you, Whitney. Thank you.
Oh, thanks. You too. All right. Bye-bye.
Bye.
Bye now.